To Lord Darzi, thanks very much for agreeing to speak to us. Obviously, we have a long association starting, just over 30 years ago, initially as a medical student, and later on as a trainee surgeon, and subsequently as your research fellow here at Imperial College.
35 years ago.
Yeah, I guess it was, yes.
Yep.
Yeah, 35 years ago.
Yeah. You're still going?
Still going. Yeah. And one thing that was quite impressed upon me was your role as a surgeon, helping deal with some very challenging cases, cancers, inflammatory bowel disease, etc. And then your transition from surgeon to innovator. And I'd love to discuss a bit about your motivation there, because obviously you're helping people with complex problems, but then your transition to helping people on a broader scale, initially with apps and subsequently with technology.
Thank you, Charles. Great to see you. I think you've got that one wrong. I didn't transition. I fairly quickly realized that if we're going to transform surgery, innovation is the only way we could really benefit patients. And you're right, in the early days, I had some big cases, mostly in cancer surgery, but also what we call inflammatory bowel disease. These are all very complicated and at different age groups. And you as a surgeon master the technical aspects of what you do. But fairly quickly we realize that actual fact, although you're doing a brilliant surgical procedure, which is curative, but you're actually making big cuts to get access to the organs you're operating on. So things were moving on in the utility of what we call keyhole surgery. And that was based on a technology which actually was invented at Imperial, but 50, 60 years earlier. The Hopkins was a reader of optics at Imperial College. He designed the Hopkins lens. And the Hopkins lens is a fiber optic, essentially, lens where you can put it through a tiny little incision and you get a full view of the abdomen and what you want to do. So suddenly that completely transformed surgery overnight, from maximally invasive operations where you have a big cut to minimally invasive procedures where we have about 4 or 5 tiny cuts. And that's the time you lived through. We had some amazing collaborative works between Europe, US. We published the first paper in The Lancet on one of the biggest cohorts ever published in doing keyhole surgery in bowel cancer. And the outcomes from these procedures was significantly better than open, because there was a lot of anxiety at the time. Are we actually doing proper cancer procedure by looking through a tiny hole with a big image? The answer was yes, we were. We were actually doing much better lymphatic harvest, which is part of the operation. So that was the early part. You were involved in that. And I think the other thing you were involved at the time is, we were the first to do this. How are you going to train the masses to do keyhole surgery? And you probably also remember a lot of criticisms to what we did at the time. A lot of from my colleagues, my peers, because that was thought at the time as being not the norm. And surgery is very conservative, if I could use that word with a small c. So we started training surgeons with these, as they used to call it at the time, how to use these instruments, the chopsticks they called it. And thanks to you, we set up a training program, and we used to, remember, every weekend we used to run a training program in one form or the other, whether that was to remove a gallbladder or doing bowel cancer, and then we did reflux surgery. So that was a very, very exciting decade of innovations in areas of minimally invasive therapies. And I was very proud at that moment, not just of the students we had, the PhD students we had, some of the clinical fellows we had. It was very exciting, very engaging time. And on the back of that, as you may remember at the time, we also won the Queen Anniversary Prize. So we went to the palace to receive that prize on the back of that. So that was the first component. But, I always said, quality is a moving target. The reason it's a moving target because innovation is disrupting everything we do today to something better tomorrow.
I mean, that was an incredible time, and it's interesting that use of technology and new ways of seeing, enabling new ways of doing things, helping people, preventing harms. You went from that incredible start, and for many people that would be enough. That's a surgical career. You've innovated, you've broken through, turned an operation that took 3 hours into one that takes 15 minutes in many cases. What drove you to go on from that, to get into the digital space?
Well, actually, in fact, the continuity of that story is how I was introduced to digital, because the decade after, and if you remember, I started working with a company called Intuitive on the west coast of the US, and they came up with the idea, could we actually completely transform keyhole surgery into more robotic surgery? So you have a robot.
Chaps, could we pick up from the start? I'm so sorry, that motorbike
Okay.
so incredibly
Okay, sure,
loud.
sure.
Thank you.
So you described the role of technology, new ways of seeing with optics, with the Hopkins telescope, which enabled surgery that took a long time to be done in a really much shorter time, and how that helped to prevent complications. Tell me a bit about how that relates to the work you did on the digital front in terms of technologies.
Yeah, I mean, digital platform completely changed everything, because that was a new platform, and how do you integrate it in some of the innovations in mechanical technologies, like robotic arms, or joints in robotic or instruments, what we call, how do we move from 3-degree movements to much more articulating joints in the instrumentation. And that led to, and plus digital, led to really embracing robotic surgery. And again, we were the first in this country to have the Intuitive robot as the partnership we developed with them. And thanks to many philanthropists at the time who helped me fund this, because NHS was going to buy a robotic system. And we essentially commissioned the first robotic program in the whole of the United Kingdom. And we were the only centre for about 7 years. And we did the first of this, first of that. Obviously, that the utility of robotics was even more impressive in the more complicated procedures, like bowel cancer, acid reflux. We did a lot of fundoplications. There was a lot of work done on cardiac surgery, revascularization of the coronary vessels by the cardiac surgeons here. And it was a nervous time, because we're trying to master this new technology, but at the same time we need to make sure that we're not doing anything that might be harmful.
Yeah.
But that was an amazing decade of innovation, absolutely. And that also, robotics significantly increased the productivity from the first 10 years, which were mostly keyhole surgery. Robotics is keyhole as well, but we were using robotic arms. And there were some unique advantages from the robotic systems. You can see much more focused views, much more magnified views of what you're operating on. You can also see the articulating arms were even much more intuitive in terms. So we did a lot of fantastic work on that, and then we combined that with imaging and innovations in imaging, and the combination of the two, and thanks to the Lady Hamlin and the Paul Hamlin Foundation, they donated a significant amount of money for us at the time to create the first robotic research lab ever, and that was the Hamlin Center for Robotics. And that expanded to look at not just robotics, but imaging and sensing, the combination of the two, and that's been going on for decades now, and with my partner at the moment, Fernando, who's been a fantastic addition. I mean, remember, we always had a clinician and an engineer working together. Even as a student, you had to have a clinician and a PhD who's doing non-clinical.
Yeah.
And the combination of the two is really where the sparks happen.
Totally. People probably would be surprised to know that obviously the work we did with virtual reality, this was again 30 years ago in laparoscopic surgery. Obviously virtual reality, augmented realities are now very common terms, but people at those times wouldn't really think it was going to be possible.
Well, again,
Pause you guys just to close those windows and
Yeah.
start with a saw, obviously.
Yeah, no, sure.
Them open again, yeah.
we should put aircon on. Aircon is on.
Oh yeah, okay.
I'm going to pick up the sound.
If you make it a bit colder, below 20, please. Thanks. So virtual reality, yeah.
Yes.
Yeah.
Okay. Are we back?
Many people would be surprised about the fact that virtual reality was being pioneered by yourself back in 1994.
Well, virtual reality was very important at the time. Let me explain what virtual reality is. Essentially, having virtual images of an abdominal anatomy, so will allow a surgeon to operate on an image rather than on an organ live in a live patient. So I saw that at the time as an amazing opportunity in training surgeons in this. You have to remember, we had to train hundreds and thousands of surgeons when it came to that, and that was based in, at the time, Centre Middlesex. We had a training lab. Then when I came here, we had a big training lab, and then I became the tutor in the Royal College of Surgeons. So, to explain the audience, what is virtual reality? Essentially, they're virtual images, and we could display them on a screen and link them to a mechanical device, where actually, in fact, the surgeon could do the same operation on a phantom, which is what the virtual images were created from. That was really transformative in training surgeons. And then we also use these images, what we call the augmented reality, where we can actually augment an image on top of an organ. What does that mean? Obviously, if you're looking at an organ, you're seeing the surface of it. You're not actually seeing its depth and what's in it. Say there's a tumor in the middle of a kidney. Augmented reality will allow you to demonstrate where that lesion is, which you can't see it on the naked eye. And that allowed us to do, for example, not remove the whole kidney. If you have tiny cancer, you remove half of the kidney. And that was transformational at the time. So both training, but also making surgery much more precise, what we call precision surgery, aided with technology like augmented reality.
It's interesting. This idea of new ways of seeing is a recurring theme, because subsequent to that, you did some work around digital platforms, particularly around understanding patients who are going to get sick after an operation.
Yeah, so we've always, and I've always had a huge aspirations to improve quality of surgery, even more importantly, the safety of surgery. And at the time, I thought, I mean, you have to remember the safety aspect is mostly behavioral. So to really get a robust research program off the ground, we had to have behavioral psychologist or other type of psychologist who could understand human behavior in many ways, and we appointed Charles Vincent. And that started the patient safety research program for us, which was quite important and big, because, you know, when you're dealing with big technology, disruptive technology, you also wanted to make sure that not only you're improving quality, but you're also dramatically improving patient safety. So once we started the safety program, then obviously, as you probably know, my itch, what are the technological platforms that could help us improve patient safety? And we had at the time one of our PhD students who, as you probably will remember, Dominic King. And his interest was digital. Could we use digital tools in helping us identify deteriorating patients? Deteriorating patients being physiologically deteriorating, in other words, unwell. And he very eloquently worked with a couple of small startups, and we developed this digital application which was called HARK in those days. And what it did, it actually captured physiological parameters of patients who were deteriorating in the ward. And that was, that happens. It still happens, but at the end of the day, how do you capture it early to intervene? And this was a digital app. You can actually pick up a deteriorating patient and immediately get an alarm and you go and intervene. And that eventually really had quite a considerable impact in improving safety within the hospital setting. At this stage, we haven't even gone out into the community in primary care. And then Google DeepMind came across, and they acquired the digital lab, and they did some interesting work on it. And obviously, so Dominic King really championed this wonderful innovation in terms of its impact on improving care, or at least avoidable incidents, by early warning systems, which is really what HARK was, a digital application. And then Google DeepMind were very keen on this. They acquired this, and at the time, these are positive outcomes. But we lost Dom because he moved to Google DeepMind, and he did a remarkable job there, and he pursued then another career and has been very, very successful. So digital transformation, by the way, still remains in my lips, as I did in the NHS investigation last year. We still see many, a huge amount of digital deficit in the National Health Service across the country. And this is a technology that's been around for 2 to 3 decades now. It's not like it happened yesterday. And you know, life is moving on. We're moving digital. We have AI, and artificial intelligence, and data and analytics. And that was another wonderful opportunity. And I'm really jumping decades now. So in the early 2000s, just before COVID was announced, we had a publication with DeepMind. To be fair, they were the great champions of the AI algorithmic development. Our contribution was the clinical side. We managed to get about 15,000 beautifully annotated mammograms from a company called Optum, I think, Optimum, which is a Cancer Research UK spin-off company. And they had about tons of this data, mammograms, which are beautifully annotated, which is actually the perfect media to train a new algorithm. And that became a Nature paper. And then since then, I mean, it's been rolled out. But again, you know, the tragic fact is we have a serious issue when it comes to diffusion of innovations. So some centres have an AI algorithm that could actually read their mammogram quicker, cheaper, and much more accurate, where the rest are still catching up with it, where you can actually roll this out overnight across the National Health Service. So these are different types of innovation. So digital hasn't, you know, digital completely moves. You know, what we're doing today, tomorrow is disrupted. We all know that.
Yeah, yeah. I mean, moving on from that idea around prevention of harm for the sick patients with the work with HARC, and then now the work you're doing in terms of flagship and preventive health. It'd be great to talk about that, because that's taking things up to the next level, beyond the hospital walls, out into the world.
Well, listen, everyone on the street will tell you prevention is better than cure. And whether that happens to be, I mean, most of the preventative measures historically we've taken have been habitual, really. How do you prevent smoking? How do you improve your eating habits? How do you prevent obesity? These are all behavioral issues, and obviously prevention has a significant role to play. But you know, that technology is moving on, or prevention of incidents, safety, quality incidents, or not quality, but safety incident is obviously the more you measure, the more you learn, the more you start improving. On the preventive side, I mean, to be fair, if you go back in history, United Kingdom would have been the top when it came to the whole issue of prevention and public health. I mean, Queen Victoria would have been probably, in my books, the best public health doctor we've ever had. And the simple reason is, if you go back in history, if it was, you know, the sewage and the sanitation improvement, that was dramatically impactful in terms of prevention of disease, but also extending life expectancy. So public health, at the end of the day, I'm saying now, I'm a surgeon, you know, at the end of the day, has the biggest yield when it comes to health value creation. And the tragic fact is that we're all preoccupied with disease and we ignore public health. So let's jump from the Victorian era. I mean, historically, infectious disease, one of the biggest killer of mankind, if you look at history, the plague and everything else. So the idea of vaccines and to the prevention of that has been also dramatic. I'm talking about a century later. And the burden of disease now, it wasn't the same as the burden of disease when I entered medical school, or even before, which was mostly infectious disease. The burden of disease now, sadly, is behavioral. It's obesity. It's lifestyle issues. And now, how do you manage that? You know, you're not going to manage that with medication, but it's fascinating. You know, we're talking about GLP-1s now in treatment of obesity, because it's very difficult to change human behavior. So, I mean, I hope flagship's one, but one of, obviously, the sector starts thinking through, let's not just treat disease at an advanced stage, let's start finding tools with the technology platforms we have, such as AI. Could we predict pre-disease states? Because all diseases have a pre-disease state. I'll give you an example. In bowel cancer, it starts with a polyp, and that polyp has some cellular changes, we call it dysplasia or whatever, and if you don't remove that polyp, that eventually moves on years later to become a cancer. Diabetes is the same. You have pre-diabetic state, you can actually identify that, and if you don't intervene at that stage, you'll end up being diabetic, requiring insulin. And all diseases have a pre-disease state, but we've never really put the investment to find what we call biomarkers. Biomarkers are diagnostic tools where we can actually look at these shifts. And Flagship very eloquent to call these the biodynamic shifts at a cellular level. So cells are starting to change, not the organ. And if you're identified at that stage, actual fact, you may be able to intervene and reverse that trend into more normal status rather than disease status or pre-disease status. So, I mean, to be honest, the best example you can express is cervical dysplasia. You know, why do women get cervical screening? Because cervical dysplasia is a precancerous condition. You can actually intervene and deal with it surgically, and you prevent a cancer. Mammography is the same, but actually it's slightly less. We're talking about cellular rather than imaging level. So I hope, by the way, that's the only hope we have in sustaining health systems, because, you know, most healthcare systems, I mean, look at the US, they're spending 20% of their GDP on health. We're spending near 10% of our GDP on health. It's not affordable.
Well, this kind of comes to what drove me really in setting up MTech Labs, is because as a plastic surgeon, you know, we're dealing with the end state of a number of behaviours. Either somebody drives a car off the road and you end up with multiple trauma. Somebody ends up with burns after an accident. But if you go back and ask the 5 whys, why did that happen, and then why did that happen, it comes back to behaviour in a large degree. And I've always been fascinated, again, inspired by much of the work that you've done, about what behavioural signals we can pick up. Not in this case in ITU or on the ward, but actually in the home and in the real world. My mother-in-law had Parkinson's disease, and, you know, sadly I recognised it before she did, before her family members did, because obviously being clinical I recognised the signs, her lack of facial expressivity, her very, very subtle pill rolling tremor in her thumb, and subsequently she was diagnosed, and watching her deterioration was tremendously impactful on me. The signs were all there and are available to be measured with advanced sensors, and that's one of the reasons why I felt, obviously being a glasses wearer, you know, and I know that at least 50% of the population wear glasses. This is a platform that can enable quite unique data, both facial expressions, which can give indications of mood, indications of chronic neurology like Parkinson's, stroke, dementia, but also things such as dietary behaviour. And I've only really gotten into the whole dietary behaviour monitoring in the last few years, and just seeing just the tremendous role it plays in mood, in obesity, and hence in diabetes, and then all the things that diabetes causes in terms of cardiovascular risk, people losing limbs, losing their sight, etc., etc. Obviously, you were very influential in MTech Labs as our first investor, and obviously being somebody who has really shaped the vision around prevention. What do you think about the potential role of technologies, wearable technologies, in the future of preventive healthcare?
Yeah, I mean, listen, prevention is a big, complex area, and some of it is behavioral related. I mean, we're talking about obesity and the obesity pandemic we're living through. Obviously, a small percentage may not be behavioral, but most of it is behavioral. And I think it's the biggest burden on disease of humanity at the moment globally. And I still believe that, you know, behavioral interventions, good diet is the way to do this. But, you know, I say this with a degree of caution as well, is that, you know, we also are very irrational species in terms of our behaviors, and that hasn't really moved on the needle per se. And we're seeing now some very innovative, disruptive innovations coming through, like the GLP-1s. In actual fact, it's not just treating obesity, but it's also treating many comorbidities. But, you know, that's the extreme. There are many, many technology platforms that we can use, like what you're developing, which actually could change the behavior. So imagine every time you eat something, your glasses will give you a caloric intake based on the size of the plate and what's on it, and in which you say, well, actually, in fact, I could eat something else instead of this, and that my calorie intake will be within this. So, yeah, I mean, innovation in that field and what you're doing is very, very exciting. I just cannot imagine a future in which we are treating and preventing obesity by needles and injections. There will be definitely an expansion in the current criteria, because I do believe in that, but it's tackling this problem with a multiple different prong of approaches, and one of them is what you're doing, which I think is very, very eloquent, especially if you know, you don't know what you don't know. When you see a plate in front of you, it may look beautiful, but you don't really know the caloric intake of that and the health impact of that. So what you're doing, you're enabling, or at least you're empowering a consumer to understand what they're about to eat may have consequences on their health and their and obviously whether they're diabetic or obese, it doesn't matter.
One of the things that really surprised me, just getting into the research on this, was the role of eating rate. I had no idea that just the speed at which a person eats has a massive role to play in the subsequent metabolism of what they've eaten.
Yeah.
That fast eaters are more likely to gain weight, are more likely to develop metabolic syndromes, are more likely therefore to develop complications, and that by slowing eating down can actually reverse these things,
yeah.
and has been shown to cause a weight reduction. And I'd love to show you a demo of the technology as is now on that eating rate thing, because it's such a simple thing. It seems kind of almost too simple that giving people real-time feedback on that dietary behaviour can have a role. I guess much in the same way that having feedback on your steps can get people motivated to exercise more.
There is even amazing science on you. Mastication, for example, which is chewing, actually creates certain hormones. The more you chew, the more it suppresses your appetite.
Yeah.
And you're right, absolutely. And giving that feedback is critical. Because your hunger rates dramatically increases as well. We know that from science. The quicker you chew food, so the more meals you're going to have, and obviously the time where you eat is also. So, you know, these are the types of technologies which could be very useful, especially with the adolescents, because, you know, they're so technology prone. They probably would embrace that type of thing better, considering all their behaviour is based on a social media utility of an iPhone. So why don't you change your eating behaviours?
I am
to a limit, by the way, because you can push that to the other extreme, which is disastrous.
Yes.
In other words,
overly focused.
probably,
I'll never forget, there's a chap you operated on, you may not remember, 7-hour operation, I think it was, something like that. He had this terrible inflammatory bowel disease, and it was just horrific. And it's one of those conditions that kind of haunts me in a way. It's now recognised that many bowel diseases are related to diet. But one of the things that was interesting to me, just reading about some of the uses of technologies in monitoring bowel function, is how recognising what a person eats relates to how they feel, and how one could use the technology to actually time surveys or at least assessments in relation to diet. And even potentially identify intolerances, identify triggers for gut symptoms, and potentially even to objectively measure the interventions such as drugs or even surgery post-treatment.
Absolutely. Listen, there are huge value pools in all of this, and I'm delighted you're exploring a fair bit of them, and there is even more that you can do in that field, because historically, and I'm a scientist, you're a scientist too, you know, we haven't really put a huge amount of effort in behavioral sciences and the consequences of that, because if you start with the poor, that's how you're going to consume food very quickly without chewing, and that has a gut impact. You know, all of that should start at school level. These are behaviors you teach kids from the beginning rather than at the end. You know, I come across some, you know, 15 years ago we used to be frustrated to be having dinner with someone who's a slow eater. In actual fact, that person was cleverer than the rest of us, because they were chewing the food well. It's amazing, it takes years to understand the science, which is, and you know, what you're doing is great, because you're actually engaging that subject in their own debate about their own health, rather than, it's sort of, if you like, in many ways, personalised preventative interventions, rather than telling the masses, you know, you should chew your food this much. Just no one's going to listen to you.
No. I spoke to a woman last week who has, she's lost a lot of weight, GLP-1s, and I asked her about her own environment, her family environment, and her mother's had 2 episodes of bariatric surgery, initially a gastric balloon and a gastric bypass operation, and has regained weight. And she's telling me how her mother eats really, really quickly, and this patient herself is also a fast eater. And one thing that's really interesting is that she's learnt that from her mother. She's had the issue herself, and the consequence of her behaviour on her own kids is also there. You know, we all think about obesity being partly genetic, but also there's a behavioural aspect that is somehow contagious, if you like.
Yeah, it's behaviour. You learn from your parents the way they eat. You're trying to do the same. I mean, all that's a behavioural issue, no doubt.
Yeah.
I mean, there's also cultural issues as well. You know, there's still some parts of Europe, for example, you go to, especially in France, you actually sit around a table, you sit down, and their lunch, and I'm not talking about a Saturday or Sunday lunch, I'm talking about a week lunch, could take about an hour and a half of lunch break. That's very cultural in France. And, you know, if you look at what they eat, which is, you know, some of the most richest foods, but they're all the majority are very healthy BMI raised than we would be in the UK. So, you know, it's bigger. There is a bigger picture here which we need to look into. It's attitudes, and you know, we've become very much, you know, food in hand, even walking and eating, which is ludicrous.
No, exactly. I mean, mindless eating is something that I've done in the past, but luckily, you know, if you're able to burn off the energy, it's fine. Over the pandemic, I saw patients gain huge amounts of weight because they were no longer able to exercise, to go out as much, and also the impact of the stress and the emotions was also a factor. People comfort eating.
Yeah, that's different era. Sadly, the pandemic has had many sequelae which are still having a huge impact on the demand in the NHS, as I witnessed in the report. And it's not just access times, it's just the burden of disease has dramatically increased.
I'd love you to try our current prototype of the glasses. These are for dietary monitoring. They are obviously 3D printed at the moment, but to give you an indication of what can be done in terms of monitoring behaviours. They have a downward-looking camera that can capture what the person's eating and use AI to analyse the calorie content. And if we were to take something, say some nuts, can give you some real-time feedback on your chewing behaviour. So if you were to just take some nuts and take a few bites. So the glass is basically a monitoring in real time. See there, as you pause.
What does that show?
This is showing how fast you're eating. And if you start again, as you eat more.
This is low eating now.
Yeah.
Gone up again.
Yeah.
Well, that was amazing, Charles. I mean, you're really putting a lot of effort into something that could be as simple as giving you a biofeedback to the individual in terms of not the caloric burden of what about they're eating, but also how could they use the chewing much better physiologically for their own health. And that's remarkable, having the two together, because essentially you're engaging a citizen in not just the quantity of the diet, but also the quality of digesting that diet. So that's remarkable. It's easy, it's simple, it's cheap. You could do it at home, and that's fantastic. You know, it's one of many things we will be doing in the field of encouraging people to be healthy and, you know, moving from treatment to prevention, which is, as Secretary of State has suggested.
Well, Ara, I really appreciate the time. I know how busy you are, the huge work you're doing on fields ranging from antibiotic misuse to global health. I really appreciate your time. Thank you so much, both as our first investor into MTech, but also as a mentor and a guide over these years.
Pleasure, Charles. Wish you the best.
Thank you.
Thank you.